We're delighted that Nasim is here today to give her perspectives on healthcare innovation, and its future. Furthermore, we're very pleased as a school that our next chancellor, for those of you who don't know, Julio Frank, who will be arriving in January, also has a health background. He's has a tremendous career in academic public health, but also in public service. He was health minister in Mexico, served as executive director of the World Health Organization, and he's keenly looking forward to the opportunity to build out the healthcare research and innovation ecosystem in UCLA and the region. So I think there are many, many great days ahead. So why don't we get started? Because we'd love to hear from you. And I'll get started first with questions really about your role and where Oracle is going. And it's been interesting to see that since the pandemic, a number of companies, Google, Salesforce, Delta, Uber, Oracle, have created this role of chief medical officer or chief health officer. And that's the role that you currently hold at Oracle. Can you tell us why we are seeing that trend and whether you expect that trend to continue?
Yeah, absolutely. I want to make sure, is the mic on? Are we good? Okay, perfect. Well, first of all, thank you, Tony and Anderson, for having me. Such an honor to be back. And as my kids will attest, I was super excited to actually get to come out and get to spend time with you all. It's really interesting to see the proliferation of chief health officers across many industries. And I think for the most part, it stems from two different areas, Tony. One is, for some organizations, they need a role in charge of health for internal reasons. And then for others, they need it for external reasons. And I'll kind of get into that. For some companies, because healthcare constitutes so much of the expense in the organization, they need someone overseeing health to make sure that employee health is advancing and moving forward in the way that they expect. So everything from prevention, chronic disease management, to low-cost medication use, that there's someone who is overseeing the house and making sure that employees continue to stay healthy. We know that massively contributes to productivity and the ability of organizations to be able to effectively move things forward. That's one class of chief health officers. Then there's another class that's around external benefits of having someone who's looking at healthcare. And that's whether you are a healthcare organization or not, you want to be part of the $4 trillion industry in the US. And if you go global, it's much larger than that. And you want a piece of that. You want to see how your company and the products that you have or the services that you offer can be engaged in that economy. And so having someone who's helping you strategically decide where to take that becomes really important. And then rarely you kind of combine two. For me personally, my role is 100% on the external side. It's about how do we really bring the technologies that are necessary to advance healthcare. But the proliferation of the role, I think, has two major sides to it. Okay,
and great. And so you were chief health officer at Cerner. And then you were acquired by Oracle. I believe it was the biggest acquisition they've ever made, $28 billion.
Yeah, it's not a small check, right?
That's right. And by the way, is it one big check?
It's a very big check, Tony.
I didn't finance my whole career. I just didn't know how big those checks were.
It's the big check class. That's.
And so how did your role evolve? Chief health officer at Cerner. How has it evolved at Oracle? And what are the opportunities you see now that you're part of Oracle, this sort of mega corporation that has interests in a wide variety of fields?
So, I was on the healthcare delivery side for the large majority of my professional career. I'm going to not do the math and give you a year. Just understand it was a lot of years. I moved to health tech because I was really excited by the potential that at no time in the history of humanity have we had so much data and the technology to actually make intelligence out of that data and be able to advance health and care. When I moved to Cerner, and for those of you who don't know, Cerner is an electronic health record company. So when you go to your doctor's office, when the doctors sit and they enter information at the computer system, there are kind of two major systems in the US, Epic and Cerner. Epic has the majority of shares in the US. Cerner is the largest EHR company globally because we have a very large global footprint. That's where that data goes. When I moved to Cerner, it wasn't my fascination with electronic health records. It was with the fact that it was the largest data repository from patients across the globe, and we actually could look at it and understand things about health and care that we did not before, and then leverage that to really be able to advance that. The acquisition of Oracle was really exciting because Cerner was already global. And I don't think this is exactly a term, but I will say Oracle is more global. They also work across healthcare delivery systems that are not just Cerner clients, but also Epic clients. They work with retail, payers, food and beverage. So all of a sudden that aperture of the people who are interested in healthcare, how do we leverage technology to advance healthcare, got really, really wide. And the technologies that we had to be able to advance things also broadened. So it went from the electronic health record to now got to learn a whole host of new terms, including cloud and data lakes and lake houses, and I don't know, there's a lot of fun terms, and heavily involved in artificial intelligence, machine learning. And so that was kind of the transition that was really exciting, Tony, was both the scope and scale of impact and the tools to be able to advance it changed significantly with the Oracle acquisition.
That's great. And so, I talked earlier about school priorities, but one of the themes across really all of our activities is the role that data and new technologies are playing in disrupting, transforming virtually every industry and role in management. And so I want to talk a little bit more about data and the possibilities for artificial intelligence in healthcare. It seems like one of the most promising areas in virtually every aspect of it. And you're on Oracle Health Steering Committee, is that right, regarding artificial intelligence? Where do you see the really great opportunities? And then I'm going to steal from one of the questions that students asked in advance. Where do you see the ethical boundaries?
Yeah, that's those are the two sides of the coin, right? So I started our AI ML steering committee in healthcare because we had AI and ML expertise in lots of different groups. So in the financial sector, in retail, in analytics, and I brought all of those people together to look at how do we actually decide what direction we're gonna move in. And a lot of that starts with what is the need now, but what do we anticipate the need to be in the future if we normalize by what's going on in the market and where we see healthcare going. And really kind of together coming up with the vision of how are we gonna leverage AI and ML to move things forward. Overwhelmingly, the focus is on how do we create more personalized care and ensure that we are in that reducing the administrative burden in healthcare. And part of why we got there was when it comes to healthcare, safety has to be the number one priority. And there's still a lot about, I'd say there's a lot that's known about AI and ML and healthcare. There's a lot less known about generative AI and healthcare. But in all of those areas, we're still learning and studying heavily. And so we have to make sure that safety concerns are number one. But there are significant areas where the communications that patients receive are very standard and can feel really depersonalized. And so people don't feel like they need to act on what the healthcare delivery system is requesting. So if you're asking someone to, let's say, do colorectal cancer screening, leading cause of death in men and women, if you combine the two groups together, if you're sending a generic letter to everybody, people know when they're getting generic letters. You're not likely to act on that. Now, if you're leveraging AI in that case to say, hey, we know you're at higher risk because of this family history, because of these elements of your medical condition, and we're strongly urging you to come and get screened, that has a very different weight for the person. So creating personalized care is an area where with really high degree of safety, you can promote better healthy behaviors. And alongside that is the other balance, which is we ought to make sure that we don't crack under the weight of healthcare costs. And so how do we actually reduce some of the expense and the administrative burden that exists in healthcare? So if, again, you have more personalized communication and you don't need to have social workers or case managers calling in and asking people to come and get screened, or you can tee up these lists of people who are falling out of their prevention and be able to tee things up in a more intelligent way for the case manager, social worker to now deal with higher priority patients versus kind of everyone. All of that kind of helps reduce administrative burden and helps deliver ultimately better results. The ethical considerations, I think, are really key. And I think as we've seen in recent years, as a society, we are not the best in adopting technology and being very thoughtful about all the different ways that it impacts, especially the most vulnerable members of our society. I'm specifically thinking about the proliferation of social media, which has a lot of good, but also has led to rise of anxiety, depression, suicidal ideation, suicide, especially in teenagers and teenage girls. We have to be far more intentional about the technologies that we implement and being thoughtful about what are the ethical implications and the adverse events to make sure that we are thoughtfully implementing. And we have robust debates on that, both internally, and we also participate in a lot of groups externally to talk through that.
So you touched on this a little bit, but I also know that health equity is a major focus for you and your team. And I've heard some kind of pretty remarkable statistics. For example, in LA County alone, longevity differs by as much as 15 years, depending on your zip code. So that's just in our own county. And so if you could touch upon how AI, for example, may help us bridge these gaps, and in general, so how you hope you and your team will make an impact on improving access and improving equity in healthcare.
Yeah, absolutely, Tony. This is something that I feel very passionately about, and I've been working on since I was in medical school. I mean, from my perspective, health equity is health. Period. End of story. The health care that people get across populations has to be standard of care, has to have the highest quality, safety, has to be culturally competent and thoughtful. And we have this vision for health equity where this kind of started off as a tease, but it stuck, and the team feels very passionate about it, which is our goal is to ultimately make sure that the woman in LA is getting the same care as the child in Rwanda. And I was the woman in LA when we were talking about this, but we were talking about some of the global work that we are doing. And the fact that not only is care highly variable within this country, when you look at care across the globe, there are some major gaps where we really have the knowledge to be able to close those gaps. So what's our responsibility in making sure that we are addressing that? There are a number of really exciting ways in which AI and ML can help with that. And I think technology, not only can it help connect things, it brings down the cost of being able to do some of this stuff. We no longer need to have the heavy brick and mortar of healthcare. Through technology. You can build the systems that can help care for people and then triage up the few people who actually need to be in a brick and mortar healthcare delivery system. One of the things that I'm really proud of, and I was sharing this with you earlier, is we have a consortium of our healthcare delivery systems that have come together and agreed to share their patient data anonymized for the sole purpose of advancing science. And we have people from all across the globe who can come up to the consortium and say, hey, we're trying to figure out this question. Can we use the database to be able to answer questions? And it goes to the consortium of clients. They approve it. So they have full authority over that. That's kind of one arm of it. So we have researchers all the time who come and look at how can they understand the data better. The other arm of it is the group also is looking at how do we advance the health of this population. And in that, we work with a group that focuses on clinical trials. So again, for those of you who are not familiar, when we run out of conventional standard of care therapies for a variety of illnesses, people can look to clinical trials, which are test drugs that you could try to see if you can help move towards better health. And the challenge with clinical trials is that a lot of times patients have to go and try to find a clinical trial, which, again, I have to say as a physician, even I struggle with that. If you find one, it's likely at a very large academic medical center. While we are massively fortunate to live very close to a number, many people in the United States live more than 4 hours out from an academic medical center. And again, having been on faculty at UCLA for over a decade, we had people from all over the world who would come to get access to life-saving therapies. That's just not practical for everyone. What this organization does is that they look at this database and they run it against the clinical trials available. And if they find a patient who would potentially qualify for a clinical trial, because you have to do some further testing, they can then de-identify the patient and reach out to the healthcare delivery system and say, hey, do you want to reach out to this patient? It looks like they would qualify for this clinical trial. Then they help support the healthcare delivery system in going through the IRB process, because you have to go through an institutional board review to make sure that you are compliant with delivering the clinical trial, and then they actually deliver the life-saving therapy to the patient in their community. The magic of all of this is that through technology, we actually have 3x the diversity in clinical trials than what is reported in national clinical trials. We also can fill clinical trials a lot more quickly. It breaks my heart that many clinical trials get closed because we can't find enough patients to fill them. Not because there aren't patients, but because it is inhumane to have someone at the most vulnerable part of their life go through this system to try and figure out where they fit. So I think that's, again, a really great example of how you can leverage technology to be able to close those gaps.
Yeah, that's wonderful. That's a great example. I'm going to move to the macro, and I know this is a question that we could probably spend hours on, but there's a lot.
We've got hours, right? I thought we'd go until 10.
I'm happy. Yeah. There's a lot. We hear a lot about the U.S. healthcare system. We spend roughly twice what other developed countries spend on health, but we have okay, not great outcomes, and not everybody's covered, so we don't have universal access. So when you look at our system, I'm Canadian, so I come from a single payer system. When you look at the U.S. health system, what are the biggest challenges that you see in improving outcomes and reducing costs?
So we have until 10 p.m., right?
Yeah.
And you got some markers and we've got the whiteboard. It's really disappointing to me as a physician, as a healthcare executive, as a parent, a daughter, that our healthcare system is what it is today. This is not what people deserve or what they should be getting. The great thing is it has a solution, which is tell us the solution. If you go back into the history of why the healthcare delivery system in the U.S. ended up where it is, it definitely is understandable how it evolved to this point. But I do think that at this moment, sitting here today, we all should be very unhappy and wanting a change in how we move forward. Because this is not the system of the future, and it's only going to change if we all say that we deserve better when it comes to both the quality of care that we get, the safety, the cost of care. The areas in healthcare that are major problems, and there's a lot written about this. Again, if you haven't looked at or read the quintuple aim, I think that kind of captures it really well. But when it comes to quality and safety of care, when it comes to patient experience, cost of care, provider burnout, and health equity, those are kind of, major gaps. And, we talked about health equity, which again, it just blows my mind that, well, it doesn't blow my mind. It breaks my heart that a Black woman in this country has 3 to 4 times the chance of death post childbirth than her adjusted white cohort, even after we adjust for socioeconomic status. Like, that to me is absolutely unacceptable. And the fact that this persists, whether you are in Los Angeles or you're in rural America, and that standard of care and best-in-class practice is actually known and not more expensive, but less expensive than what we have. So if we had until 10 p.m., I would tell you about why we ended up here. I will give you the synopsis of what we need to do to get out of this. And I am biased, but I think sitting here in 2024, technology has to be a major tool that we use to be able to get there. And I'm going to say it has to be a major tool because it is a tool. And I get very worried when people think that this is going to be the panacea for all of our healthcare problems. It's not. What's going to move this forward are people. There are people like all of you. It's our healthcare providers. It's our caregivers. It's patients and families. But technology is a tool that can be leveraged to say, are we delivering the quality of care and the safety that we need? Are we making the provider and caregiver jobs sustainable so that we have more people going into this field? Are we making the cost of care sustainable so that we don't end up having to impact things like education or cost of infrastructure because healthcare cost is so much? So it really can be the connector in our ability to move through these domains that are a gap.
So I'm going to just ask a couple more questions, and then I have some questions that I got from students in advance, and then we'll open it up to all of you. But I actually now, the next question, you may have partly answered it because it's really a question about your personal journey. You went from a career in healthcare delivery to a career in healthcare technology. And it sounds like you're a tremendous believer in the power of technology to have sort of a widespread impact. Was that a part of the motivation for your personal journey from delivery to the roles you're in now?
Yeah, absolutely, Tony. So I'll give you an example of part of what motivated me. And apologies, let me. So I practiced as a hospitalist at UCLA, which means I take care of adult patients who are acutely ill. For an adult to end up in the hospital and be hospitalized, usually, we have to be doing pretty bad for that to happen. So you get really sick patients. I was on service one time, and my team had admitted a patient with heart failure the night before. And in the morning, when I came to the hospital, the team was presenting this case, and they were super excited because they never get such an easy case. And they're like, Mr. Smith came in, he couldn't breathe because he was in heart failure, and that's when your heart doesn't squeeze as well. So fluid backs up into the lungs, and people can't breathe as well. It's like we gave him all these medications, and they listed them all and got the fluid off, and he's feeling great this morning. He's walking up and down the hallway. We are ready to discharge him out of the hospital. I was like, okay, well, that sounds like a pretty easy case. I speak with him. He's doing great. He's ready to go. Right before I was ready to say, okay, he's good to go, I was like, why did you end up in the hospital? I was looking back at your records, and it looks like your heart failure has been really well managed. Do you have any ideas what's been going on? He's like, no, I've been taking all of my medications, and I went through his medications from home. Yep. He's like, I've been taking them all. It's like, okay, no changes in medications. And I'm kind of trying to think, like, why is this guy in the hospital now? And, maybe this was the cynical physician part of me where I'm like, is he really taking the medications? And I kept like pushing on that. And I think he kind of got tired of me because he sensed that I was suspicious. And he was like, listen, I lost my job recently. I know how important these medications are. I'm spending all my money on these medications, which are super expensive. I don't even have time. I don't even have money to buy food. I'm like, wait, what? So what are you eating? He's like, well, I'm just eating whatever's on sale at the grocery store. I'm like, okay, give me an example. It's like, well, there's like can of beans, there's like can of soup, there's like, it was all like cans that were discounted. Now, the problem with cans, there's many problems with foods and cans, but one of the major problems if you have heart failure is that it is very rich in sodium. And if you take high sodium foods, it holds on to water in your system. If you have a heart that doesn't pump well, you now just added a ton of pressure with additional fluid, and the heart fails. So he was doing all the right stuff, bless him. He knew that his medications were important. He was spending all his money, because we're not in Canada, buying his medications, which he otherwise had no access to, but he had no money for food. And the sad thing to me, Tony, is that we actually should have known that he lost his job, because not only should we have asked, but we should have known because he did not have insurance. And because outside of the 37% of patients who are on Medicare and Medicaid, the other large proportion is employer insurance. We should have known that he doesn't have insurance. The medications are going to be a problem. Potentially other stuff are going to be a problem as well. And so we would have let him go, I am sure, only to have had him come back over and over again, because what he really needed was social support for food, which we were able to provide for him. So for me, kind of the genuine passion in moving to healthcare technologies was, we have the information. We just need to be able to connect it so that we can make better decisions. I talk about the 80% problem, which is 20% of what determines someone's health is what happens within the four walls of a medical system or a healthcare delivery system. The 80% of what determines your health is where you live, where you work, your habits, your genetics. At what other place in life have you ever tried to solve a problem, especially a complex problem like healthcare, only having 20% of the information that you need? And then we wonder why decade after decade we haven't made progress. So for me, being in a space where you can connect the 80% with the 20% and have insights and intelligence that can then move forward health and care was the motivation to move to health tech.
Okay, well, that's a great reason. I'm going to just ask a couple of questions that we got from students in advance, and then we'll open it up to the floor. This might have, when we talked about having till 10 o'clock. And
this is a 10 o'clock question.
This is one of those questions. I love this question. I'm not sure which student submitted it, but I'm just going to read it verbatim. And understanding the healthcare ecosystem is made up of multiple players with sometimes competing interests and dynamic regulation guidelines that fluctuate over time. How do you identify the best opportunities in a system like that? And one of the reasons I love this question, I'm going to do a sort of a back to our strategy. When we're thinking about what are the capabilities that we want to develop in our students that would allow them to be transformative, one of the key features of it is that you really have to have deep industry acumen. You have to understand how, where the flows are, who are the players in the system, to really be able to understand how to innovate, how to spot an opportunity and then act on it. And in this kind of Rube Goldberg system that we have, I'm going to rephrase the question that way. How do you identify opportunity in this really complex web of players and incentives?
Yeah, that is a great question. By the way, whoever came up with that should get a solid A, maybe an A plus even. It's part of this broken system where we have multiple stakeholders who are trying to do the same thing, but are creating a lot of chaos and confusion coming at it in different ways, right? So you have healthcare delivery systems, you've got the payer side, and then you have a whole host of retail players that have come forward and are trying to play in this space. And then I'm not even going to, because they're much smaller, talk about food and beverage, which is also trying to get into health really in a big way, or like the wellness industry, which is like $130 billion. So I'm gonna kind of leave those folks to the side and just say, even within the major forums in which people are trying to access or get health, that there's a lot of back and forth, and there's a lot of confusion. If you're a glass half full kind of person, which I am, I will say what's really great about this exact moment in time is that the costs of healthcare have become so challenging for us as a society, and the trends have become so challenging that it's actually pushing everybody to work together in ways that they never did before. So the healthcare delivery system has to work with the retail, and not all of them do, but there's way more collaboration than ever was before, with the retail to say, hey, if a patient just needs a quick blood glucose check for their diabetes, or they need to get their vaccine really quick, like, how does that work, and how do we get that information then back into our system? That the payer is working closely with the healthcare delivery system in a way that they did not before, and transitioning from their purely transactional role, which again, it's still quite transactional, but it is evolving to how do we come together to actually make sure that we are delivering better care. Part of being able to connect the data is going to help facilitate that. But I think back to the question of opportunity, there's not really a shortage of opportunity. It's very easy to be super busy in healthcare, but not really move things forward, or move things forward incrementally, but not fundamentally move things forward. Where I think is really, things are getting really exciting at this point is that different industries are looking at how do we come together to be able to create value that wasn't there before. And it's purely because of the economics of this, whether it's that there is so much money here, people want to have a part of it, or that margins are shrinking in other places. Again, that's part of there's so much money here, or this is just costing too much and we have to figure out a solution around this.
So this gets perfectly into the second question from the students, and then I'll open it up. So it sounds like strategic partnerships are going to be really critical in this kind of evolving ecosystem. What do you look for in partners at Oracle? What are the qualities that you're looking for in partners that you want to enter into strategic relationships with?
Yeah, so I'll answer that, and I'll do you one better. I'll tell you also what I was looking for on the delivery side. On the healthcare technology side, you're looking for innovative players who want to do something that's fundamentally different, but who are also wanting to do that at scale, because scale here really makes a difference. You want to be in markets and be able to do things that are going to really have broader impact. And you don't want to be with traditional organizations who are happy with how they're making their shareholders happy today. You want to be with people who are really thinking about the next, which means you may be financially suffering a little bit in the short term, and you have to be comfortable with that. You want a diversity of partners, because different groups are owning part of this. Food and beverage is trying to figure out, how do I make sure that when you come into the grocery store that you're making good health choices, because some big food and health beverages also own pharmacies and are trying to do health stuff on the side. And so they're kind of trying to connect those pieces. So we're kind of looking again for innovative, scalable, and then kind of diverse businesses. When I was on the delivery side, in my COO role, I really looked for a lot of startups who are thinking differently about healthcare, because in healthcare delivery, we don't really have the DNA for what we have to do to think differently about things. We're so ingrained in how things are today that it's really difficult to think differently. We actually started up a VC arm to not only invest, but bring startups in to start creating kind of that DNA for being able to do things differently. And again, looking for stakeholders who wanted to tackle different parts of that quintuple aim. So there's definitely plenty of opportunity for partnership.
Great. Well, thank you. So now I'll open it up to any of you. If you don't mind, if you can go to the microphone.
Thank you so much for sharing your insights. I want to kind of expand on the 50 little countries thing, and Dean Bernardo brought up, living in Canada and their system. More than ever, this younger generation, so millennials, Gen Z, and then the future generations, are moving away from their parents. And so you're changing companies, changing insurance providers, which means you have to change doctors. More and more, we're becoming accountable for our own health records and making sure that they get transferred, which is an onerous process. So how is Oracle facing this new dilemma faced by the younger generation of having to be more accountable for keeping track of their own health records and their health care in general?
Yeah, that's a great question. So my first piece of advice is never move away from your parents. That's just say that. I tell that to my kids every day. I'm gonna say that here too. Right? That's good advice. Thank you. But secondly, and again, I'm going to preface this by saying this is solely my opinion, because I think industry is going to look at this in terms of kind of what is the market used to, what's the incremental transition with which it needs to move forward to, and both Epic and Cerner are going to continue to move along in an incremental way. going to be super excited if that doesn't happen. But what I think absolutely has to happen is that health and care records belong to the individual. Again, I am old enough to have been sitting in leadership meetings where we actually had this conversation that was like, wait, but we as a healthcare delivery system own the records. So I'm glad that we are past that conversation, because that health and care information absolutely belongs to the individual. I think what we are going to need in the future, and this is going to be the evolution of this, or at least I hope this is where we go, is we need to have a unified platform that pulls in all your healthcare delivery system data. So your 20% is now on a platform that is cleaned, it's normalized. You can apply AI and ML to create intelligence out of it, but it also enables you to have your 80% of data that also then connects with the rest of that. Because you as the consumer should have full line of sight into, again, not just what happens on the delivery side, but what happens more broadly. Again, I'll go back to a patient with diabetes is going to benefit just as much as having access to their endocrinologist record as how what they ate is impacting their blood sugar, which is not something that their endocrinologist is going to have line of sight on. But for once a year, maybe if they're super lucky, 4 times a year. But you can actually manage that on a hour by hour basis because you have access to that data. So I think the evolution of that is going to be different. I think it was critical for us as a country to undergo digitization of the medical records. Again, I trained at a time where I trained on paper and pen, and people would stuff things in their pockets and you couldn't find the cardiologist note, and that was not good. So I am glad that things are digitized. It has helped us significantly. But it's not what's going to get us to where we need to go in the future. When it comes specifically to electronic health records, the majority of the U.S. is covered by 2 electronic health records, and then there's like 3 others that, depending on if it's ambulatory or other spaces, are kind of there. And then there's a bunch of small ones. One would think that would be great, because if there's 2 major ones, like we should be able to get a lot of data back and forth. And what's interesting to me, because I spent the majority of my time within Epic Systems, and then the last 3 years have been on the Cerner side. So I feel very comfortable saying both of them don't serve the purpose that they need to today, that they fundamentally need to be thought of differently as we look at healthcare in the future, for us to actually create personalized healthcare that makes sure that we are delivering the highest quality, that it's safe, that it's pulling information from lots of different places, so healthcare providers are not burned out and exhausted. And even within an EHR. So I got my healthcare all at UCLA, and then when I went to UCI to be their COO, I got my healthcare there. It was fascinating to me. Two Epic sites. UCLA kept thinking I was not getting the care that I needed, even though I was just at UCI, and I was like, hey guys, it's University of California and you're both on the same system. Like, why is this not talking? So that whole system is broken. All of this to say, you're right. It's like 50 separate areas and then some. That's why I keep going back to the 80% problem, because that information, so even the 20% is broken, but even if we were to fix the 20%, all this other data that determines our health isn't connecting to the 20%. And so there are obviously national regulations around interoperability, and everyone I can tell you is compliant, because you can't be an EHR and not be compliant with it. It's still broken. So that needs to be updated and enhanced. And some of it is technology issue, but really a lot of it is not. So that's something that has to evolve and has to get better. And then the other thing that we have to insist on as consumers is that it can't just be about the 20%. Because what determines my health and well-being is not what happens in the healthcare delivery system. As amazing as my healthcare delivery systems are, it's what I'm eating, it's how much I'm exercising, it's my sleep, it's all of that stuff that leads to diabetes, hypertension, depression, anxiety, all the things that ail us. So outside of kind of acute things that we get, which is a small portion of the population, the majority of what determines our health is the 80%. And so we have to connect all of that and get rid of the 50 different parts. The second part of your question around the for-profit component of that, and I'll preface this by saying this is solely my opinion. Again, as a physician, a parent, a child, a sister, I strongly believe that healthcare should not be for profit. That does not mean that you do not make money, right? You can make money and not be for profit. You can put the money back into communities. You can put it into drug discovery. You can put it into all sorts of different places. I do think that when you look at making money off of people's healthcare, that sets up inappropriate incentives that doesn't end up benefiting the population. And again, that is my view. I think it's very sound when you look at the data, but I do think that poses a challenge. Again, what I will tell you, though, as a glass half full person, is that regardless, we are having to reckon with the quality of care and the cost of care. And so we're having to go back and look at all of that. So one great thing about having a healthcare cost that is unsustainable is that it does force us to look at it as all the different stakeholders in healthcare. And I am optimistic because I believe in the economics of this, not because I believe in what we're doing, but because of the economics of it, I'm very optimistic that we're going to end up in a much better place.
I have a question. I really love this talk and how you've really mentioned the 20% of data that may be captured within oracles from within the four walls of the hospital. And then there's this 80% of data that happens in everyday life. I'm curious how Oracle is thinking about capturing some of that 80% of data into the EMR, and what's the role that consumer wearables play within that?
Yeah, that's a great question. So I'll say right now, there's no platform that looks at how do we pull all of that together. And again, that platform ultimately, from my perspective, needs to be owned and managed by the individual. Personally, I'm not a fan of having all of that in an electronic health record, because I think that is not inherently the right model for the future. I think the right model for the future is that you own the platform, you pull in your data, and then you choose to share it when and where you need to share it. But that's exactly the kind of data that you need. Like, again, it's amazing to me. We have all these wearables with all this data, and we don't end up using it to advance someone's health, right? If you're super motivated, you'll kind of use it to modify some behaviors, but there's elements of that you're not even thinking about that could potentially be beneficial, and we're missing all of that. I used to wear a number of different wearables because I love data, and I took them all off because I'm like, I'm not doing anything with this, and no one knows what to do with this with the rest of my health data. And I think that's an opportunity lost. I think we have a tremendous opportunity to pull that together. So let's solve that one together.
Let's do it. I love it. Thank you.
Great. Yes, please.
Hi, Dr. Afsar. It's nice to meet you. One of the things that kept crossing my mind as I was listening to you speak is the problem with ED boarding right now.
That's a problem.
Yeah, right. I actually think that, it's not as macro as some of the other things we've talked about, but I think it's really indicative of some of the cracks and problems with the system. And for folks who don't necessarily know what ED boarding is, I promise I'm going to keep this quick. It's basically when you have a 40-bed ED, but you have 80 people who have been admitted to the hospital. They have nowhere else to go because there's no room upstairs. And so they stay in the ER, and then you have a waiting room of 30 to 40 people just sort of pickling. And I think that one of the questions that I had was, how does something like AI or machine learning technology in general sort of help alleviate this problem, which is contributing to physician burnout and, bad Press Ganey scores and, patients getting worse care.
Yeah.
Because I'm seeing them in the waiting room rather than a private room.
Yeah.
I'm doing procedures in a hallway because I don't have any geographic space.
Yeah.
So yeah, I think that was the big question that was running through my mind, is like, this feels like a very physical problem, and I'm not sure how technology contributes to a solution to it.
So that's actually the type of problem, Reza, that AI/ML is well poised to address, and we actually routinely leverage that for throughput issues within a hospital, because you can predict with far more accuracy than anything else what you think your census is going to be in a particular area. What's the staffing that you're gonna expect? What are the patient types you're going to have, and how many hours of nursing care you're going to need based on that? I mean, I remember again when I was on the wards, you had a nurse manager who would sit down and say, okay, like, these 4 patients are yours, these 4 patients are yours. Now you can actually run algorithms that are like, these 4 are best suited for this nurse because of his expertise and the number of years in practice that they've been in, the complexity of these 4. We're not going to give you like the sickest 4 people. We're going to balance that for you. Similarly with ED boarding, you can anticipate those ebbs and flows a lot more and do much more flexible staffing, which I know we're not a fan of. We like our things to be standard, but we have to function that way if we want to use real-time data to make real-time decisions. But you can actually staff more appropriately. The problem is you can't ad hoc create physical space, but if you do have the staffing for it, at least you're not going to have pickled patients in the ER. You can at least treat patients and be able to care for them. But those operational problems are actually ones that are poised really well for AI/ML solutions.
My question to you is on the employer responsibility. When you mentioned healthcare being more equitable and you mentioned employer costs, HRAs and other types of benefits that are being implemented by employers have been a huge perk that have risen in the last 10 years. You see fertility, you see mental health, you see a lot of other types of benefits that are getting implemented. And there's a lot of data showing that they're driving down medical spend cost as well, where you're getting more education, medical experts, and more just vetted information in general from these. To you, what do you see being the longevity of this? Because I feel like there's a certain extent of how many employer benefits you can bring on that will offset. We still have medical insurance spend, and we still have the premiums to pay as an employer.
Yeah, that's a really great question. I think in a number of different ways, that's a really great question. I'll say kind of the first thing that came to mind as I was listening to you is, it's so phenomenal that we have these, and because it is a competitive market, more and more places are looking at offering these as a competitive benefit. But gosh, it's really wrong that people who either their employer doesn't offer that or don't have the right employment don't get these benefits. And so everything that you mentioned is something that everyone should have access to. And I worry when it comes to benefits is that when you have a downturn in the economy or there is margin shrinkage, that those are the things that go, and now you're playing with people's health and well-being, which is also not appropriate. So I think this again kind of goes back to the broader cost equation, which is when you do better care for people, it does drive down the costs. It does lead to more productivity. So how are we balancing that so that we could provide those benefits long-term for everyone? The way our system is set up in this country, unfortunately, makes that challenging in lots of different ways, because as you know, the employers and the payers who pay and support healthcare costs are not the ones who necessarily get the benefit further down the line. Because as we were talking earlier, people move, and you are investing in someone where you're not kind of picking up the future benefit. This is why some other systems end up working out really well, because ultimately, if the government is responsible for you from birth through the transitions at the end of life, not to say that that system doesn't have any issues, but in this particular case, if you're responsible for that, you're making decisions and supporting your citizens in a very different way. So to me, it's like we have to look at the broader cost equation to make benefits like that something that is universal for anyone who needs it.
Thank you. Yes, please.
Thank you for coming. My question is, with the 80% in mind and the huge rise in retailers during COVID and post-COVID, how much data is too much data? And thinking about your own Oracle employees, with us consumers having access to so many new technologies, at-home testing, wearables, all of these new supplements, what do you think are things that will last versus things that might be trendy?
Yeah, that's a really great question. I think there is a lot that's going to be trendy. There is a lot in the wellness side that has evolved over the last, I'd say mostly 5 years, but it was definitely there before. That's at very high cost, but it does not impact health. I think a lot of that stuff is going to end up being trendy. I think things that are going to stick is through COVID, we learned that retailers could be a really powerful ally in being able to provide some key healthcare, and understanding that people will actually leverage that was really great data to have. Because again, I also remember being in executive meetings where we said, we are UCLA Health. We are a U.S. News and World Report top 10 organization. No one's ever going to go to CVS to get a flu shot. Like, they're going to come to us because they want to. No one's going to go there for their diabetes. They're going to come to us. And I think one of the things that got proven in COVID was that people are going to look for access. And if you don't have access and that's the easier access, you're going to go there. The other piece I will say, again, having traveled extensively across the country, for a large number of communities, the retailer is actually the place where they can get care, because they have to otherwise drive 2 or 3 hours for basic stuff. So I've had some very fascinating conversations with some retailers who are like, I'm going to put some healthy fruits and vegetables for sale because, and this is like, you would never see this never see this in Westwood from them, but they're going to do that out in those communities because they're seeing patients come in and this is like the stuff that they're looking for. They're like, oh, I need to stock diabetes care supplies. I need to stock hypertension supplies. I'm going to put a mobile clinic in my parking lot. Like, people are having conversations because they're realizing that there is power to access. And I think some of those trends are going to continue because those are kind of the points of access that we have today. I think as we mature as a society and a healthcare delivery system, all of that has to get standardized and has to be done in a much more intentional way than it is today. Thank you.
Well,
of course.
Thank you. I know we could stay till 10, but we really appreciate that you took the time to be with us. It was a fascinating conversation.
Thank you.
Thank you so much. And we're very proud that you're an alum of our FEMBA program. And we're so proud that you're having an extraordinary positive impact on society. So thank you for that.
Thank you, Tom.